Hello, everyone, and welcome. I'm Sarah DeFeo, Chief Program Officer at Ovarian Cancer Research Alliance, and I'm so glad you've joined us today for this important conversation about endometrial cancer and the growing role that genetics and biomarkers are playing in how we understand and treat this disease. We'll be hearing from two leading experts in gynecologic oncology who will walk us through everything from how to understand a diagnosis and what testing is available to the newest treatment options and clinical trials. We're also proud to be joined today by Dr. Josefa Briceño from AstraZeneca, our sponsor for this event. And we'll be leaving time for your questions after each speaker, so please submit those in the Q&A box at any time. You will need to enter a first name on the live stream page to ask your questions and view comments. You can post anonymously by toggling a button. Also, if someone else has already asked your question, please click on the thumbs up icon to upvote it and push it toward the top.
Hi, everyone. I'm Audra Moran, President and CEO of Ovarian Cancer Research Alliance, and I want to thank all of you for coming today to this very important seminar. We have over 1,000 people registered, and we're thrilled to have you here. And we're honored that you took this time out of your day to spend with us to learn more about endometrial cancer and the role of genetics and biomarkers in treatment decisions. So you're going to hear today from our expert speakers on the growing importance of this genetic testing and biomarkers in understanding endometrial cancer. And you're also going to hear about advances in precision medicine that are shaping more effective personalized treatments. I'll tell you a little bit about OCRA. We are the world's largest organization dedicated to fighting ovarian and gynecologic cancers, and we recently expanded our mission to include all gynecologic cancers. And we're proud to support those impacted by endometrial alongside those facing ovarian and other types of gynecologic cancer. Our work includes supporting patients and families, funding life-saving research, and advocating for stronger public policy and education. Our impact is huge, actually. We've funded over $128 million, which we're very proud of, in research funding, and that is here in the US and internationally. This year, we plan to fund at least, we hope, $10 million more dollars, so we are very proud of that. We've helped secure over $3.8 billion in federal funding for gynecologic cancer research and education, and we support over 95,000 individuals every year. So one of the most important things that we do provide is education for patients, and like the seminar that we're having today. So we believe knowledge is power, and we're really committed to making sure patients and families have access to this latest information. We also have a powerful advocate leader program with hundreds of volunteers from around the country who raise their voices on Capitol Hill, and they do grassroots action at home in their own states to push for policy changes and increased funding. And through our woman-to-woman program, we provide one-to-one peer mentoring and an array of support services. We offer community, guidance, and care for everyone impacted by these diseases. I invite you to visit our website at ocrahope.org. That's ocrahope.org. And for those of you attending today whose lives have been touched by endometrial cancer, we hope that you'll join us in our mission as we grow to serve the full gynecologic cancer community. Thank you so much for being here. I hope you find it valuable.
So hello, my name is Josefa Briceño, and I am the franchise head of medical affairs in the United States for gynecologic and genitourinary cancers at AstraZeneca. And at AstraZeneca, it is our mission to eliminate cancer as a cause of death and to offer new treatments for those patients living with cancer, including endometrial cancer. And we're very pleased to be supporting the seminar hosted by the Ovarian Cancer Research Alliance to help bring expert insights directly into the hands of patients and, very importantly, caregivers. So, despite endometrial cancer being the 6th most common cancer in women worldwide, there have been limited advancements in treatment options until very recently, even though the disease burden is increasing. And that's exactly why continued innovation is so critical to ensure that those vital tools like biomarker and genetic testing improve earlier diagnosis and treatment and ultimately improve patient outcomes. And I do know that for all of us, it is a priority to ensure that endometrial cancer patients have access to all the information they need to be active participants in their treatment journey, especially as they navigate complex treatment decisions. To that end, our work of AstraZeneca continues to challenge and to redefine the current clinical paradigm of how personalized treatments can be used to target the disease. and improve patient outcomes through cutting-edge research and technology. And more specifically, we're known to have introduced immunotherapy into areas of high unmet need. And this, of course, includes endometrial cancer. Everything we do is centered about bringing new and innovative treatments to patients. So looking ahead, we pledge to continue collaborating with our partners to progress the treatment paradigms for patients and prioritize education, innovation, and patient-centered care. And alongside our work with various patient advocacy groups like the Ovarian Cancer Research Alliance, we are doing everything we can for patients by supporting programs that amplify public awareness and education of endometrial cancer. So in conclusion, thank you again to everyone who has made this event possible, including the experts, panelists, and attendees who are participating today, and to the broader scientific and medical community who are advancing research in biomarker and genetic testing to ensure more targeted care for patients. We are very grateful to be a part of this community and to help improve the lives of patients with cancer.
Thank you, Dr. Briseno. Okay, let's get started. So our first featured speaker is Dr. Ann Klopp, who is a professor of radiation oncology and head of the gynecologic oncology section in radiation oncology at the University of Texas MD Anderson Cancer Center. Dr. Klopp is both a physician and a scientist with a research focused on making radiation therapy more precise and effective for women with gynecologic cancers. She leads MD Anderson's brachytherapy program, including its cutting-edge use of MRI-guided techniques, and she's actually a former OCRA grantee. She serves as a principal investigator for clinical trials and co-leads the HPV-related cancers Moonshot program. And if that weren't enough, she's also a dedicated educator, helping to guide the next generation of oncologists through her work with the American Board of Radiology and the American Brachytherapy Society. Today, Dr. Klopp will give us an overview of endometrial and uterine cancers and help clarify the difference between genetics and biomarkers. She will also discuss the most effective testing strategies currently available and help guide treatment decisions. After her talk, we'll open it up for your questions, so please keep them coming in that Q&A box below.
Hi, everybody. My pleasure to be here today. We're going to be talking about endometrial cancer and some of the new developments that are influencing our treatment recommendations. In particular, we're going to talk about molecular markers and biology. So we're going to go through a series of learning objectives. The first thing that we're going to talk about is endometrial cancer and what defines endometrial cancer. We're going to talk about biomarkers, both molecular biomarkers and histologic biomarkers. We're going to go through a few of these specific biomarkers that have become very important in deciding about the best treatment for endometrial cancer. And then finally, we're going to go through the treatment guidelines and recommendations very broadly for endometrial cancer and do that overview. So endometrial cancer arises in the endometrium, and the endometrium is the lining of the uterine cavity. And you can see here shown in blue the endometrium, and in yellow endometrial cancer, which can arise anywhere within that blue endometrium. The other sources where uterine cancer can arise include within the muscle of the uterus itself, or the myometrium, the cervix, which is part of the uterus, but typically is a very different type of malignancy that is HPV driven. And then within each one of those segments, there are different features of malignancies from those sites. So we're going to be focusing on the endometrial cancers today, which are the ones that arise within that endometrial lining. So an opportunity with endometrial cancer is that patients very often develop early symptoms from endometrial cancer, specifically vaginal bleeding. And so for any woman who is postmenopausal and develops vaginal bleeding, it's very important to do an endometrial biopsy. And this shows what that endometrial biopsy involves. So a thin straw is placed into the uterus, and the endometrial lining is sampled for the pathologists to investigate and see if there's any evidence of malignancy. So the important take-home point there is that anyone with endometrial, with uterine bleeding, vaginal bleeding, should undergo an endometrial biopsy. Endometrial cancer is largely a disease of higher socioeconomic countries, and so in the US in particular, in Russia, and in parts of Europe, the risk of endometrial cancer is much higher than in other parts of the world. The reasons for this are not completely understood, but are thought to be related to obesity and to other dietary changes, and may also be related to lifestyle differences. So a lot to learn about this, but the distribution of endometrial cancer is very clearly uneven throughout the world. The incidence of endometrial cancer is continuing to increase and is expected to continue to increase. To some extent, this is thought to be related to aging of the population, but is also probably related to these dietary and environmental changes that are thought to influence where endometrial cancer is seen around the world. And the risk of endometrial cancer increases with age, and so that happens fairly steeply in the 50s and 60s, where the risk of endometrial cancer becomes much higher. The other risk factors for endometrial cancer are largely related to estrogen exposure, and so adipose tissue in particular results in secretion of estrogen, which can stimulate the endometrium and lead to the development of endometrial cancer. Also, some forms of hormone therapy can increase the risk of endometrial cancer, in particular when estrogen is given without the balancing progesterone that is typically given with hormone therapy. Tamoxifen, which is a treatment for breast cancer, can also stimulate the endometrium and lead to the development of endometrial cancer. And anovulation, reduced progesterone production, is also a risk factor. The relationship between adipose tissue and endometrial cancer is very strong. So as BMI increases, the risk of developing endometrial cancer also markedly increases. When we look at outcomes following treatment for endometrial cancer, we can see, first of all, that the risk of having surviving endometrial cancer is very much related to both the stage and the morphology. So morphology here means the histology and what the pathologists see under the microscope. So you can see this red line up at the top is for the lowest risk histologies at the earliest stages, and the outcomes there are very good. The risk of it coming back is very low. When we look at the patients with high-risk morphology but early-stage tumors, you can see that there is a slightly lower rate of survival, but with an uptick in the recent years, suggesting that some of the new treatments are resulting in better outcomes. The outcomes for patients with higher-stage tumors are somewhat worse, and there's a lower risk of patients developing recurrence of their cancer. How about genetic mutations and how they influence the risk of developing endometrial cancer? So there are syndromes that are very well described that are heritable, such that a mother may pass them to their child, and they can run through a family and predispose to the development of malignancies. Lynch syndrome is one that is very well known for its relationship with endometrial cancer, also colon cancer. It affects 1 out of 279 individuals. The BRCA genes, which are best known for increasing the risk of breast and ovarian cancer, can also increase the risk of endometrial cancer, and that affects about 1 in 400 women. Cowden syndrome is a much less common genetic syndrome. It's a mutation in the PTEN gene, and it predisposes to developing endometrial cancer. And finally, the PPAP syndrome is a rare syndrome, but involves a heritable mutation in the POLE gene, which we'll talk more about. Each one of these syndromes has a differential effect of predisposing the individual to get endometrial cancer. So Lynch syndrome is associated with a 60% lifetime risk of endometrial cancer, so quite high. So many women with Lynch syndrome may choose to have their uterus removed after childbearing. BRCA gene mutations are associated with a much lower risk of developing endometrial cancer. The Cowden syndrome, somewhat higher, and same thing with PPAP syndrome. So very important to distinguish between germline mutations, which are heritable changes that are passed on to offspring and are also present within tumors themselves. And these mutations, for example, we talked about Lynch syndrome, involves the tumor itself having the same mutation. Now, the tumors have to go on to develop other mutations in order to become malignant, but the hallmark that is present in every cell in the body is also present within the tumor cell itself. And this contrasts with a somatic mutation. So this is a genetic mutation that occurs within the tumor only, and it is not passed on genetically, but many of the same molecular changes can happen within the tumor itself. It's important to recognize that women with endometrial cancer are still at risk for developing other diseases. So here, this is a graph comparing the relative risk of dying of endometrial cancer and the risk of dying of cardiovascular disease for a woman who's known to have endometrial cancer. And so what you see is in the first couple of years, there's an increased risk of dying of endometrial cancer. But as years go by, the other medical issues such as cardiovascular disease can be equally as much of a risk. So a very important part of the process of describing an endometrial cancer is when the pathologist looks at a tumor under the microscope, and what they see under the microscope is the tumor cells themselves and the context in which the tumor cells are identified, and that leads them to a diagnosis, which includes a histology like endometrioid, serous, or clear cell, and also a grade, which reflects how aggressive the tumor cells look. And this description is independent of stage, which is a descriptor which of course relates to where the tumor is found, including within the uterus, within the lymph nodes, or distantly. The process of histology involves taking the tumor section, putting it onto a physical glass slide, and then staining it with different stains that identify cytoplasm and DNA, and then careful expert review by pathologists to identify these tumor types. Entirely separately is the process of describing which mutations are present within tumors. So this is an example of a common mutation in endometrial cancer in the mismatch repair genes. So these mismatch repair genes, they normally repair mutations that occur during replication. And if they are mutated, mutations occur at a high frequency. And so tumors themselves can be hypermutated. And as it turns out, interestingly, this presence of hypermutation is a strong predictor of benefit from receiving immunotherapy. Another mutation that can occur in endometrial cancer is in the polymerase epsilon gene, or POLE. And when that POLE gene is mutated, it results in a protein that can't do its job and can't accurately replicate DNA, and you wind up with many, many mutations within the tumor DNA. And those many, many mutations also, like mismatch repair deficiency, create a tumor that the immune system can recognize and represent a tumor that is likely to benefit from the addition of immunotherapy. Another gene that is frequently mutated in endometrial cancer is called P53. So P53 is, unlike these other genes that we were describing that have a role in DNA replication, P53 is known as the guardian of the genome, and what it does is it prevents transcriptions of genes when there has been mutations like the ones that predispose to cancer. When the cell starts to divide in an unregulated fashion, it prevents transcription from happening. And so what happens when P53 is mutated is it can no longer do its job. It can no longer be this guardian of the genome, and you wind up with transcription of many genes that result in developing the malignant phenotype. And what we know about those tumors is that chemotherapy is actually the most effective treatment. So I mentioned that these tumors, that many mutations, are immunogenic. And what immunogenic means is that the body's immune system can recognize them as foreign, much like the body's immune system can recognize an infection as foreign. And so what happens is that the tumor cells themselves, they have these many, many mutant proteins, and the immune system, here shown as this green effector T cell, can recognize these mutant proteins and can actually kill these tumor cells. And so if this process is allowed to function, the body can get rid of tumor cells itself, and immunotherapy is a way of augmenting that process so that your body's own immune system can recognize and destroy tumors. So with these molecular subtypes, we can categorize tumors into 4 different groups. And so the polymutated tumors are the ones that have a mutation in this polymerase epsilon gene that results in many, many mutations present in the tumor. And we think these tumor cells are able to just naturally be recognized as foreign and eliminated. And so these poly tumors have an excellent prognosis. And you can see that as the blue line. So 100% of women are free of relapse after 5 years. For patients with the 2 middle groups, the mismatch repair deficiency and the no specific molecular profile group, they have an in-between prognosis, so some risk of the tumor coming back. And the patients with P53 mutations have the highest risk of relapse. And so this is where we can say that these are prognostic biomarkers. So they tell us about the prognosis or the risk that the endometrial cancer will come back over time. They're also predictive, which means they can tell us which treatment is going to work. So here's an example of a trial where patients were treated with dostarlimab, which is an immunotherapy drug, and patients with mismatch repair deficiency drove a much greater benefit from that drug than the patients with no specific molecular profile that you see there on the right. So we learned here that mismatch repair deficient tumors are really the ones that benefit from immunotherapy. And so what that has led to is a new generation of trials where women are assigned to a group where the treatment options are the ones that are best known to be of benefit to patients with that tumor. And we know that from going back through trials that have been done where hundreds of women were treated with standard options and doing the same molecular classification process. And so we have found out which treatments are most beneficial, and we're asking how we can refine that further in the next generation of trials. Also important is that we've learned that women that have endometrial cancer that have recurred in the pelvis can still be treated very effectively with radiation treatment. So this is an example of a woman who was treated originally with vaginal cuff radiation and developed a recurrence in her pelvis on the lymph node region. We treated it, you can see in the middle square there, with radiation treatment, eliminated the tumor, and she went on to live many years free of endometrial cancer. So it's very important to acknowledge that when endometrial cancer recurs in the pelvis, that we can treat effectively with radiation treatment alone. This is a clinical trial where we compared radiation to chemoradiation for locally recurrent endometrial cancer and found that chemoradiation did not appear to further improve outcomes, but that many women were effectively treated with radiation treatment only after having had recurrent endometrial cancer. So let me briefly go through treatment guidelines for endometrial cancer. Now, of course, this is a decision that every individual should make with careful discussion with their physicians. And there's a lot of nuances and subtleties to this, but just to broadly go through the recommendations. So for women with early stage endometrial cancer, so this means confined to the uterus, women with grade 1 or 2 endometrioid cancers who do not have any invasion of the do not need any additional treatment. So they are effectively cured of or likely cured of their endometrial cancer with just surgery. For women with myometrial invasion and grade 1, 2, or 3 tumors, we oftentimes recommend a kind of radiation treatment that just treats the top of the vagina called vaginal cuff radiation. And then finally, for women who have grade 3 tumors or invasion into the cervix, we often recommend pelvic radiation, which treats not only the top of the vagina, but also the lymph nodes. In some women, we'll also recommend chemotherapy as well, particularly if the P53 mutation is observed. And then for women with node-positive cancer, so these are stage 3 tumors, if they're low grade, we oftentimes recommend radiation alone. If they're higher grade or have high-risk histology, like serous or clear cell, or have P53 mutations, we'll recommend chemotherapy as part of that treatment. We've learned that women that have mismatch repair deficient cancers, that immunotherapy is a very important part of the treatment, and that those patients should receive chemotherapy and immunotherapy. and typically do not need radiation. And for women with no specific molecular profile of endometrial cancer, we recommend chemoradiation followed by chemo if they're node positive. And so that means they're not mismatch repair deficient or polymutated or these other things that we talked about. So that's a very broad overview of treatment recommendations for stage 1, 2, and 3 endometrial cancer. So finally, just my conclusions. So endometrial cancer is increasing in incidence, and I think really warrants more investigation and more research so that we can prevent that increased incidence and come up with more effective treatments. And we know that endometrial cancer can arise in women who are genetically predisposed, but also women who are not. The primary treatment is a hysterectomy with some type of nodal evaluation, and adjuvant treatment will depend on the features that we find at the time of pathology. Pathology assessment requires pathology review and molecular subtyping, so specifically looking at that poly mutation, looking for the presence of mismatch repair deficiency, and looking at P53 and whether it's mutated or not. And then ultimately, our treatment recommendations will depend on both these molecular features and the histologic features, and ultimately may involve some kind of combination of chemotherapy, radiation, and immunotherapy. That concludes my presentation. Thank you so much for joining us here today. I'll be happy to take any questions.
Okay. Thank you so much, Dr. Klopp. That was wonderful. And we do have a whole bunch of questions that have come in for you. So if you are ready, we will get right into it. Okay, so the first question, we have some questions come in about the causes of endometrial cancer. Specifically questions like, can benign cysts cause endometrial cancer years later? And can extreme stress cause endometrial cancer?
Yeah, I think the answer to both is no. There are certainly, the real cause of endometrial cancer, as with all cancers, is developing a mutation in the DNA of normal cells. And when these normal cells develop mutations, they start to divide more quickly, and then that results in developing more mutations. And so the risk is related to the risk of exposure to developing things that give you mutations in DNA, part of which just come from aging and life. But part of it comes from the factors that we talked about that predispose to endometrial cancer, like estrogen exposure. So benign cysts are generally not predisposed to endometrial cancer. So those things are not things we need to worry about in terms of increasing risks of endometrial cancer. And then the extreme stress one, I think stress is so complex. And while certainly there are factors that are related to being stressed and also being related to cause cancer, most of the time they're unrelated to one another. And so while good for all of us to try to control our stress and to maximize our health. Also, I think important not to feel worried that there's something that one did in one's life that caused them to get endometrial cancer. It's just the way biology works is that it's a sort of independent process.
Right. Got it. Thank you. So 2 more kind of basic questions that came in. Can you get endometrial cancer after the uterus has been removed? And can endometrial cancer cells start in the endometrium and grow or move onto the ovary?
Yeah, those are good questions. And so endometrial cancer by definition starts in the endometrium. So if the uterus is removed, you should not develop endometrial cancer. Now, there are some situations where people have had a diagnosis of endometrial cancer, their uterus is removed. They may not have even, for some reason, been aware of that, although certainly we wouldn't expect that would be something that we would be aware of because pathologically it would become apparent. But after having had endometrial cancer, it can come back in other places. So a common place for endometrial cancer to come back is the top of the vagina. And the thought there is that those cells are able to survive and grow in the environment of the top of the vagina, where after surgery, the GYN oncologist will sew the vagina back together again. And that's a place where endometrial cancer can grow, even though there's no endometrium, but those cells that originated in the endometrium develop the ability to grow in that spot. And then with regards to the question about the adnexa, definitely it is a place where the endometrial cancer cells can grow, and they start in the endometrium, but then they can pass through the fallopian tubes and they can find a hospitable environment in the ovary or in the adnexa, and they can grow there.
Great, thank you. You talked a little bit about in your presentation about the heritability of endometrial cancer in some cases, and we had a question about genetic testing and how often should genetic testing be performed, is the question.
Yeah, so it's very personal, and it depends on what the individual's family history is and what their personal history is of cancer. Genetic counselors are the experts in having these conversations, and so a lot of times a GYN oncologist will refer a patient to a genetic counselor to talk through the testing. It's a constantly evolving field as we learn more about different mutations, and so a common way that it happens now is that somebody may want to see a genetic counselor because they have a family history of endometrial cancer or of another cancer that is also linked, like colon cancer and Lynch syndrome, or because their individual tumor showed features that suggest that there may be a heritable component to it. And so when that happens, the process is that you go to see a genetic counselor and they talk through which tests might be appropriate and how one would go about interpreting them and what one might do depending on the results of those tests. So that's a really good way to get some more information.
Great, thank you. And I just want to mention for everyone listening that OCRA does have a free genetic testing program. So I would encourage you to go to our website, find out if you're eligible to participate in the program, but it is a great option. Maybe we can put some information into the chat with the link to the program. Okay, moving on, we received 2 questions about biomarker testing, both focused on what to do if someone did not have tumor testing or biomarker testing at the time of diagnosis. One person now has metastasis to the lungs, but is told that it's difficult to biopsy. And the other is saying that she only had germline testing and wants to learn more about her cancer. So any guidance here on questions that they may ask their doctor about how they should proceed?
Yeah, so there's definitely always an opportunity to repeat a biopsy and to redo those tests. So it's not that if they're not done in the beginning, they can't be done later, can be done in the future. The process involves, getting some tissue in some form or another, and the process for that depends on where the spot is that needs to be investigated. Lung biopsies, it sounds like in this case, if they weren't sure about being able to do a biopsy, it may be because it's a very small spot, and sometimes that happens. And so it's something that might be revisitable in the future. And then at any time when they take a biopsy, they can do the molecular testing that is recommended. And that's not only the things that I talked about, but a lot of additional molecular tests that are being done now for prediction of which novel treatments may also be effective in the treatment of endometrial cancer. So molecular testing is a really constantly evolving and growing field, and it is an opportunity at any time if somebody has some tissue available that can be biopsied and be investigated.
Thank you. Follow-up question, are there any additional screening recommendations for those with a family history of endometrial cancer? This person says, I'm worried for my daughters after my endometrial cancer diagnosis and want to be sure they know all of their options. Do you think there are genes that have not been found yet that cause it?
Yeah, I think that's a great question. I definitely think that we see families where a cancer runs in the family and we don't necessarily know why. And it probably is because there is some gene that is not yet totally been identified as the risk factor for that individual. But we are rapidly learning more about that as more and more often the entire genome of tumors is sequenced. There are less and less secrets about what might be present in the tumor and what in some cases might be passed on. The good thing about endometrial cancer is that being vigilant to vaginal bleeding is a great way to identify endometrial cancer and to prevent it from advancing and being a more harder to treat cancer. So I think, thoughts are being vigilant about vaginal bleeding, pursuing an endometrial biopsy with any symptoms, after childbearing, can have a hysterectomy, obviously a conversation with your GYN oncologist to talk about that. And then for people who've been diagnosed with a syndrome that increases the risk of colon cancer, also colonoscopy is a really important part of screening for colon cancer and a great way to prevent them from ever developing. So there's a lot to do to prevent that cancer risk, which is, one reassuring aspect of that.
Thank you. Okay, so a few questions about recurrence have come in. How common is metastasis of endometrial cancer, and what are the typical sites? What is the best way to discover a recurrence for endometrial cancer? And please clarify when a PET scan versus a CT scan is necessary. So sort of three-part question.
Yeah, no, great questions. In terms of the risk of endometrial cancer coming back, a lot of it depends on some of the features of the original tumor. And so there are some types of endometrial cancer where it's much more likely to come back locally, like the top of the vagina, like I mentioned, which we treat a lot with radiation and can be cured very effectively even when it's recurred. And so for certain endometrioid types in particular, it's likely to come back either in the pelvic lymph nodes or in the top of the vagina. For patients with high-risk histologies like a serous cancer or a P53 mutated cancer, it may be more likely that it'll recur throughout the belly, throughout the peritoneum. And then all endometrial cancers have some risk of spreading distantly, and that can be liver, lungs, or bone. Other sites are less common but possible. Like the brain, for example, is not a common place for endometrial cancer to come back, but it can. And so the ways to identify those things, one is a symptom that is something that is sort of new and worrisome. And I know that's kind of vague, but a lot of times people come and say, oh, I have this like ache and pain that comes and goes, and that is probably not something to worry about. We all have aches and pains that come and go, and probably that's not something that warrants careful investigation. But if somebody ever has something that is a new symptom, like a new pain or a new cough or a new something that is worrisome and getting worse, that warrants investigation. And a CAT scan is usually the first go-to test. A CAT scan gives us really good anatomical visualization of enlarged lymph nodes, anything in the lung, and is a great test. A PET scan is often done in conjunction with a CAT scan, but in addition to having the anatomy, has metabolism of a sugar molecule that is radio labeled. And so you can see what parts of the tissue are consuming extra sugar, and it gives us some functional information. And so where that's particularly helpful is where you have an anatomical abnormality, but you want to know, is there living tumor in there, or is that just kind of a little thing that's there, like the top of the vagina, for example. We don't always know if it's a normal spot or if there's uptake in it, or a lymph node can be normal sized but have uptake in it in a PET. So the CT is usually the go-to, but in certain situations, a PET adds information.
Thank you. Okay, a few more minutes here. Next question is about tissue report. And the question is, can the tissue report be helpful in advising female children and siblings about any inherited potential for endometrial cancer?
Yeah, so the tumor tests can give us a signal that there may be a germline mutation. So when they see abnormalities in the mismatch repair proteins, analyzing the tumor, certain features are signals that there may be a germline or an inherited aspect of that. And so when those tumor tests reveal evidence of problems in the mismatch repair genes, it can warrant a test in the germline and look for something heritable. So there are some situations where that can be helpful. The tumor test tells you about something heritable.
Thank you. Switching gears, someone is curious to know if there are any specific diets or supplements to avoid if you have been diagnosed with endometrial cancer.
Yeah, I think we don't have any great evidence that there is a diet that is the way to prevent endometrial cancer from coming back. Clearly there's a relationship between obesity and endometrial cancer. And so maintaining a healthy body weight is a great way to prevent getting endometrial cancer. Once somebody's been diagnosed with endometrial cancer, it's still helpful to maintain a healthy body weight, but it is not the primary determinant of whether endometrial cancer is going to be effectively treated or whether it's going to return. And so important to have a healthy body weight, but some of it is really more determined by the cancer than by the diet. And beyond that, I think there's really no evidence that there's some particular diet or some particular supplement that's the answer. Lots of interest in that question and lots of studies ongoing, but nothing that is so strongly helpful that we recommend it for everyone.
Thank you. We get those sorts of questions a lot. Appreciate it. Okay, with new treatments, such as immunotherapies and targeted therapies, what is the rationale for continuing to receive the standard of care radiation treatment for 5 days per week for 5 weeks? And would you clarify what is chemoradiation?
Yeah. So, the radiation is very effective at preventing the endometrial cancer from coming back at the top of the vagina or in the pelvis. It is not helpful in preventing it from coming back in other parts of the body in general. And so the immunotherapy is, or especially for tumors that have those features that make them immunologically recognizable by the immune system, immunotherapy is an important part of treatment. So it's not a one or other situation. It's really based on the individual features and deciding whether it makes sense to do immunotherapy based on their mismatch repair deficient status, which is typically one of the strong signals that immunotherapy will be helpful. And then what is the likelihood that it's going to come back in the vagina or in the pelvis, being a determinant of whether radiation should be part of the treatment. The question about was the other question related to the second part of what you said?
Chemoradiation?
Oh, chemoradiation.
Yes.
Yes. Chemoradiation refers to giving cisplatin, typically is what's given weekly together with the radiation. And so that's a combination that has been shown to work very well in many different situations, not just in endometrial cancer. And the two treatments seem to synergize together. And so chemoradiation refers to receiving cisplatin together with the radiation.
Got it. Okay, thank you. Thank you so much, Dr. Klopp. That's all the time we have for questions today. I do just want to mention there were lots of questions that came in. Thank you, everybody. We did get some questions about access to clinical trials and ongoing support. So I just wanted to mention that OCRA does have a bunch of programs for people either going through endometrial cancer or supporting someone with endometrial cancer. We have a personalized clinical trial navigator on our website. We have a Staying Connected support series. We have a peer support program called Woman to Woman, all of which have specific programs for those people diagnosed with endometrial or uterine cancer. So I would encourage you to go to our website, OCRAHope.org, or give us a call for more information on those. Okay, thank you, Dr. Klopp, so much for your time.
My pleasure.
Okay, so we're just going to keep on rolling. Keep putting in your questions, everybody. Our next speaker is Dr. Eskander, who is professor of gynecologic oncology at the University of California, San Diego Moores Comprehensive Cancer Center, where he also serves as medical director of the Clinical Trials Office and fellowship director for the Gynecologic Oncology Program. Dr. Eskander is an expert in precision medicine and biomarker-directed therapies, and he's dedicated his career to expanding access to clinical trials and bringing the most promising new treatments to patients with gynecologic cancers. He's been involved in developing and leading trials for more than 14 years with research interests ranging from immunotherapy and targeted treatments to novel drug combinations and molecular diagnostics. He's also a passionate educator, mentoring medical students, residents, and fellows at the UC San Diego School of Medicine, where he also earned his medical degree and completed his residency in obstetrics and gynecology. So today, Dr. Eskander will walk us through what's new and emerging in the treatment landscape for endometrial cancer, including targeted therapies that are already in use and clinical trials that are actively recruiting patients right now. And as with our earlier session, we will follow up his presentation with a Q&A, so don't forget to submit your questions. Thanks.
Good afternoon. Thank you so much for giving me an opportunity to join you to talk about emerging therapies and the clinical practice implications in endometrial cancer. My name is Eskander. I'm a GYN oncologist at the University of California, San Diego, Moores Cancer Center. So the objectives today will be for us to sit together and review the evolving treatment landscape as it relates to endometrial cancer. And importantly, a big component of this is the emergence of immune checkpoint inhibitors in the management of this disease. We're also going to take a moment to talk about targeted therapies in the context of antibody drug conjugates, which is an area that's been evolving quite rapidly in the endometrial cancer arena. We will also discuss clinical trials and clinical trial opportunities, and we will end focusing on the importance of clinical trials and drug discovery. Endometrial cancer continues to have a substantial national and international burden. As illustrated here, we recognize that endometrial cancer has a rising incidence and mortality, and as of last year, exceeded the estimated number of annual deaths in comparison to ovarian cancer. And this really highlights the unmet need and the importance of continued discovery in the endometrial cancer space. We've seen a progression, and this schema here really highlights this evolution from focusing only on histologic or pathologic criteria now to an incorporation of molecular features to guide treatment recommendations. This slide summarizes efficacy data when we looked at immunotherapy. And just to backtrack just a moment, immunotherapy really tries to harness the body's own immune system and the ability of that immune system to recognize cancer cells as abnormal and then subsequently to allow our body to kill those cancer cells. And here we see efficacy data showing that in patients that were mismatch repair deficient, this is a particular biomarker, we saw dramatic efficacy with immunotherapy, and that bordered on about 40 to 50%, which is well beyond what we saw with traditional chemotherapy. And I will pause for a minute just to make sure that everyone understands that all endometrial uterine cancer patients who have newly diagnosed endometrial cancer should have mismatch repair immunohistochemistry testing to inform treatment, but also because of the potential implications on genetic predispositions to developing the disease. Conversely, when we look at this table, we see that if we have a biomarker negative population, these are the mismatch repair proficient endometrial cancer patients, the response to single agent immunotherapy was much more modest, on the order of about 8 to 10%. In totality, about 2/3 of patients will be mismatch repair proficient, and about 1/3 of endometrial cancer patients will be mismatch repair deficient. And that really emphasizes the need for us to explore treatment strategies beyond immunotherapy alone. This slide illustrates a schema. It is a diagram that highlights the design of trials that look to examine the efficacy of combining immunotherapy with chemotherapy in patients with advanced stage or recurrent endometrial cancer. There were 4 very large international clinical trials that looked to ask whether or not adding immunotherapy to chemotherapy improves clinical outcomes, both in the mismatch repair deficient population, but more importantly, in the mismatch repair proficient population, where there was a significant unmet need. And this cartoon emphasizes the importance of putting these two treatment strategies together. We combine chemotherapy with immunotherapy because we hypothesize that chemotherapy will lead to cancer cell death in a way that will allow the body to respond better to the immunotherapy. So you take a disease that may not be responsive to immunotherapy alone, by layering on chemotherapy, we can induce what we call immunogenic cell death, create these neoantigens, these are the markers that our immune system recognizes physiologically, and then elicit a better immune response. And these studies resulted in basically 4 publications that were very close to one another temporally. And you can see here the trials, either the NRG-GY018 trial, the RUBY trial, the DUO-E trial, and the ATTEND trial, all of which looked at combining immunotherapy with chemotherapy, all of which had very provocative efficacy signals, resulting in what we're going to review to be the FDA approvals. And so what we saw initially in these clinical trials was that when you combined immunotherapy with chemotherapy, there was a dramatic benefit in the mismatch repair deficient population, that biomarker positive cohort. That was a 70% reduction in the risk of cancer progression or death. And this resulted in a very rapid assessment of the data and an United States FDA approval and European Medicines Agency's approval for the use of these combinations in the mismatch repair deficient population. But again, that's about 25% of patients, maybe 30% of patients with advanced stage or endometrial cancer. But we recognize the need to expand beyond that. And that's where we saw an evolution in these trials by showing that the combination of cytotoxic chemotherapy with an immunotherapy or immune checkpoint inhibition led to clinical benefit. And there was an approval as well in the United States of chemotherapy, carboplatin and paclitaxel, with pembrolizumab and pembrolizumab maintenance, as well as chemotherapy with dostarlimab and dostarlimab maintenance in the advanced stage or recurrent mismatch repair proficient endometrial cancer population. And that's because the combination of these two together resulted in an about 40% reduction in the risk of cancer progression or death compared to chemotherapy alone, which was the standard of care historically. And we're looking to see whether we can move the needle further. Really here I want to highlight your attention, or bring your attention, I should say, to the panel on the left and the panel in the middle, where we're trying to ask if we can abandon chemotherapy altogether in these biomarker positive patients. Can we use immunotherapy alone to try to affect an improvement in clinical outcome? And that would really be transformational for how we treat these cancers, because we wouldn't need to be using carboplatin and paclitaxel at all, but using immune checkpoint inhibition alone. These are clinical trials that we are awaiting the results on, and it will be important to review these results to help guide and inform subsequent treatment. On the very right, we did have results of a trial that looked at a combination of drugs, lenvatinib and pembrolizumab. We use these in the recurrent setting, but this trial, the LEAP-001 trial, tried to ask if we can move it earlier on in treatment. The trial was negative for its primary endpoint, but it's important to recognize that in this trial, patients who had previous chemotherapy and were enrolled on treatment appeared to respond better to lenvatinib and pembrolizumab when compared to carboplatin and paclitaxel chemotherapy. So this is informative. It helps guide us as clinicians into understanding potential sequencing, and it really emphasizes the benefit that we see with this regimen, which we'll review in just a little bit of time. Now, this is a dynamic slide, so we're going to take you through it quite rapidly here. But basically, what we see is when you have patients that are diagnosed with endometrial cancer, the treatment decisions are really dependent on what we do in the beginning of therapy. And that's because prior exposure is relevant. So when you have a newly diagnosed patient, you determine whether or not you're going to give chemotherapy alone or you're going to give chemotherapy with immunotherapy. And there's also a bucket of patients that may benefit from chemotherapy and a class of drugs called anti-HER2 agents. Currently, those are restricted to patients who are HER2 positive. And the reason it becomes a complicated course is because subsequent treatments are informed by what a patient is treated with previously. So you can see here, if a patient were to be treated with chemotherapy and immunotherapy at the time of diagnosis, at recurrence, it becomes more nuanced. Can we give chemotherapy and immunotherapy again? How long was their disease-free interval, meaning how long a period of time did they have where the cancer stayed away? Do we have to pivot to different treatments? Do we look at a combination of drugs such as lenvatinib and pembrolizumab? Or do we look at an evolving treatment on clinical trials such as antibody drug conjugates? So what we're seeing here is a dynamic time, and we're going to spend a few minutes discussing what this future may bring. So because we've moved immunotherapy and chemotherapy into earlier lines of treatment, meaning when patients are diagnosed with metastatic disease at primary presentation, we have to ask ourselves, is there a role for immunotherapy now in the recurrent disease setting? The KEYNOTE-775 trial, which is just listed here for reference, this is what brought us a combination of lenvatinib, an oral pill that targets cell signaling pathways, tyrosine kinase inhibitor class of medication, with immunotherapy with pembrolizumab. And this trial showed that lenvatinib plus pembrolizumab had a significant benefit over physician's choice chemotherapy in patients who received prior chemotherapy and progressed. But importantly, this trial did not enroll any patients who had received previous immunotherapy. And if we look at some previous clinical trials, we can see there may be a signal to suggest that in a cohort of patients, we may be seeing a benefit if we re-challenge. This was a clinical trial by Dr. Stephanie LaRue, where she said, well, if you progress on immunotherapy, can I retreat you with a combination of a drug, a pill called cabozantinib, and nivolumab, an immune checkpoint inhibitor? And they saw some preliminary efficacy. And more recently, there was a case series by one of my colleagues, Peter Rose, that again looked at patients who received immunotherapy with immune checkpoint inhibition, progressed, and then received lenvatinib and pembrolizumab with efficacy. These were all what we call biomarker positive patients. They were all patients that had mismatch repair deficient endometrial cancer. And what the benefit may be in the mismatch repair proficient population is unclear. I did also want to take a moment to talk about emerging novel treatments. You know, one of the things that drug discovery does for us is when we make a therapeutic gain, it opens up for us the treatment landscape and it creates a whole new group of unmet clinical needs. And what we know is that we're becoming much more thoughtful about drug discovery in the endometrial cancer space. It's biomarker directed discovery. So if we look here, this is the schema of the Rainbow clinical trial. And why is this relevant? Because this trial is looking at biomarker specific buckets. So instead of lumping everybody together, which was what we did historically, we're becoming more thoughtful about drug design and trying to match the molecular marker to the therapeutic treatment that's administered. We also wanted to ask, can we move immunotherapy up to earlier lines of treatment? Meaning the studies that I alluded to were in patients that had advanced stage or metastatic disease. But what about patients who have disease that's completely removed at the time of surgery but are high risk for recurrence? That was the Keynote B21 trial. That's the schema that's shown here. This was a negative trial. It did not show efficacy in adding immunotherapy in these patients, but there's a strong caveat, and that was in the mismatch repair deficient, biomarker positive population. The signal here was still quite provocative, with a 70% reduction in the risk of cancer progression or death. And so this begs the question, in those completely resected biomarker positive mismatch repair deficient endometrial cancer patients, should we be using chemotherapy and immunotherapy? And right now, that is an active conversation that we're trying to figure out. In addition, we're trying to determine whether or not there's ways to improve on what we are doing historically with HER2-directed therapies. Some of you may recognize HER2 as a drug target in breast cancer, and that is accurate. We're now wondering whether or not we can improve on treatment options in endometrial cancer by bringing these HER2 treatments into earlier lines of therapy. And this is a clinical trial led by my friend and my colleague, Dr. Britt Erickson, asking about the therapeutic benefit of HER2 targeted treatments. Now, we could spend an hour talking about novel therapies in endometrial cancer, but here I really want to put it into buckets, because we recognize that in order for us to see clinical benefit and make a difference, we're going to have to be thoughtful about our strategies. And so here we can see different targets. TP53, that is a target that is frequently mutated in certain types of endometrial cancer. So in the TP53 mutated population, can we capitalize on what we call anti-angiogenic agents? In the TP53 wild type endometrial cancers, meaning there is no mutation, can we look at selinexor, a nuclear export inhibitor, to try to improve outcomes? We can look at antibody drug conjugates well beyond HER2, and we will talk about that. We'll talk a little bit about what these ADCs are, because it is so relevant. Can we look at drugs that target DNA damage repair? And can we identify patients that may have a sensitivity to these agents and improve upon chemotherapy as a standard of care strategy? And then lastly, can we reinvigorate our ability to use hormonal therapeutic strategies, which again is adopted from diseases like breast cancer, where we have estrogen and progesterone receptor positive endometrial cancer? Can combinatorial hormonal therapies be efficacious? So as we take the next steps, I think it's important for us to level set. these antibody drug conjugates, which I imagine many of you will hear a lot about, both in the course of treatment or potentially in enrollment in clinical trials. These are drugs that use an antibody which recognizes a cell surface receptor. It could be various things. Some of you may know about folate receptor alpha, which has approved antibody drug conjugates in ovarian cancer. Tissue factor, where there's approved antibody drug conjugates in cervical cancer. While in endometrial cancer, we're also looking at HER2 targeting antibody drug conjugates, one of which has an FDA approval, TROP2 antibody drug conjugates, or ADCs that target B7H4. And these antibody drug conjugates are linked to drugs. So there's a linker, and we call a payload. And if we look at this slide coming up, we could see that what happens is the antibody recognizes a marker on the cell surface and the antibody binds to it. That allows for internalization of that antibody. It releases the payload, which is the active drug, and that leads to cancer cell death. But it's not limited to just the cell, because some of that payload is released in circulation, and we call that the bystander effect. So we get basically cell death beyond the target. Perhaps greatest excitement was brought forth with the Destiny Pan-Tumor-02 trial. This was presented and subsequently published, and it looked at an antibody drug conjugate that targets HER2. It's called trastuzumab deruxtecan. And what we saw in a relatively small number of patients was a very provocative efficacy signal. So when we used this drug in patients who had recurrent endometrial cancer, who had a high expression of the marker HER2, we call that HER2 3+ by immunohistochemistry, we saw an overall response rate greater than 80%. That was a very dramatic number, because compared to chemotherapy alone, where we might get a response of 15%, you could see the very huge clinical benefit. And that data did result in the approval of this drug in the United States by the FDA for patients who had recurrent metastatic cancer that was HER2 3+, irrespective of where the cancer started. And we're seeing more and more of these. And these are called disease site agnostic approvals, meaning rather than give a drug approval based on where the cancer started, we're giving a drug approval based on a biomarker that predicts response. And we're seeing a real growth in these disease site agnostic approvals, because we're becoming more thoughtful about the way that we're looking at our ability to identify effective drugs and therapeutic targets. This was a subset study that was done in Japan, looking at the same drug in an aggressive histology called carcinosarcoma, once again with very provocative preliminary efficacy signals, and really highlights the therapeutic benefit of these agents. But it's going to expand well beyond HER2. So you could see here in this table that we're looking at different targets, and really this is just as a broad reference. We're looking at drugs that target TROP2, we're looking at drugs that target folate receptor alpha in endometrial cancer, and you can see that these drugs are similar but also very different. They're different in how they're developed, they're different in their potential treatment-related side effects, and that's very important as we guide therapeutic decision-making for our patients. And here it's a summative slide that once again highlights these various targets and really is intended to allow you to see all of the different drugs that are exciting, that are being developed in endometrial cancer to fill our unmet need, because we recognize that therapeutic targets are needed. And it's not just trastuzumab deruxtecan, for example, in the HER2 arena. We see here that there are other drugs that are targeting HER2 that are looking to expand access, meaning not just limit it to HER2 3+ or HER2 2+. These are the expression levels that we look at in the tissue with pathology. But can we look at even low expressors, the HER2 1+? Because as you can imagine, the greater the ability to capture patients, the greater the therapeutic benefit for a larger cohort. And here is a schema for a trial looking at TROP2. Again, this is a clinical trial for patients who had prior immunotherapy and chemotherapy, and it's allowing patients to be randomized to a TROP2 targeting antibody drug conjugate versus physician's choice chemotherapy. And then this is a very similar study looking at a different drug. The prior was sacituzumab govitecan. This slide is looking at sacituzumab trimotecan, targeting TROP2, looking to improve clinical outcomes over chemotherapy alone. So, I'm excited about what the future is going to bring. Why? Because we've seen that endometrial cancer, which historically had limited treatment options, has now really blossomed into a disease where we have many active clinical trials looking at novel drugs to improve clinical outcomes. I purposely put this slide in here because I also want to speak about treatment-related side effects. Whether it's immunotherapy or whether it's antibody drug conjugates, we have many organ systems that can be affected, and that's really incumbent on us as treating physicians to be thoughtful about the therapeutic treatments that we're employing, educating our patients and making sure they're aware, because awareness, education, knowledge helps us ensure that a patient can stay on an effective treatment strategy as we look to mitigate any treatment-related side effects. I alluded to this a little while ago, but this slide highlights the schema of a study that's looking at a drug that tries to really take advantage of a functional protein, that TP53 protein I alluded to, when it's wild type, meaning it's working normally in cancer cells. And this trial is looking at a drug called selinexor in a maintenance setting, and it was based on very exciting data from a phase 2 clinical trial. And this is a clinical trial that's active and currently accruing, and we'll see what it shows. And then lastly, it's not just antibody drug conjugates. We're living in a world where we're exploring various treatment strategies. So we spoke earlier about DNA damaging agents. These are the WEE1 inhibitors for which there's a clinical trial. And I just want to highlight on the very far right here, these NCT, these are the clinical trial identifiers. This is how we speak about an active clinical trial. So all of these are active and accruing studies. There are studies looking at CHEK1 and CHEK2 inhibition. We have studies looking at a pathway called the PI3 kinase pathway in endometrial cancer. Or lastly, on the bottom, drugs that target the Wnt or beta-catenin pathway. So it seems a bit like alphabet soup, but what's promising is that we're understanding more about the biology of the cancer. That's helping us better develop clinical trials and drugs that target these pathways so that we can improve clinical outcomes, because there's a clear need both nationally and internationally for improved choices. So I know that was a fairly large amount of information, but I'm eager to answer any questions you may have. And again, I just want to highlight that this is just the beginning for us as we look to improve clinical outcomes for our patients with endometrial cancer. Thank you so much for your time and attention.
Okay, wonderful. Thank you so much, Dr. Eskander. That was great. We have lots of questions for you. Hi, I see you now.
Hi, how are you? Good to see you.
Good to see you too. Thank you so much for doing this. That was a terrific presentation. Okay, so we got lots of questions for you, so let's get into it. There was a question in the chat about symptoms, including visible blood in urine and stool. Could you please respond with your recommendations in this case?
Yeah, so I want to make sure I understand the question, because there's a difference: symptoms while a patient is on treatment or after they're diagnosed, or symptoms in the context of prior to diagnosis. I will interpret the question first about pre-diagnosis. And the most common abnormal symptom for a patient with a diagnosis of endometrial cancer is abnormal vaginal bleeding. That can happen both prior to menopause, or it can happen after menopause. After menopause, it is clear that any bleeding that a patient might experience should be worked up. It shouldn't be ignored. And I will say that in clinical practice, it's not uncommon for patients to notice blood, but it's a small amount, and it's dismissed because it's human nature. We feel well overall, and it's probably nothing. But if you experience bleeding and you're concerned it may be vaginal, then it's appropriate to have that worked up. Again, any postmenopausal bleeding. When there's premenopausal abnormal bleeding, that can be a bit more nuanced, but does warrant an evaluation also. And to the question that was pointed about urine or stool, as you can imagine, sometimes it's difficult to know definitively where the blood is coming from, because anatomically those areas are close in proximity. So if there is a suggestion of bleeding, it's most prudent to seek the advice and care of your healthcare provider, have it worked up. The evaluations are relatively straightforward and can be done quickly. A urine sample to see if there's blood in the urine, a clinical exam and see if there's blood from the vagina, and then a rectal assessment too. So I hope that answered the question, but I'm also more than happy to elaborate on that if needed.
That was great. Thank you. Okay, so many people in the seminar today have asked why the most common first-line treatment is platinum-based when there are so many new treatments and ways to find treatment that's personalized to the individual. So the question is, will there be a time with new treatments when radiation is not necessary? I guess that's an additional question. Yeah.
Really excellent question. And I'll take it as two pieces, as you alluded to. The first is the platinum part. We are therapeutic evolution in cancer care is stepwise. And for a long time, carboplatin and paclitaxel have been the chemotherapy backbone. But we are making advances and recognizing and identifying new strategies for treatment. But usually we work from more advanced stage disease, and then we take those effective therapies and we move them sequentially into earlier lines of treatment. Our hope collectively is that we will be able to take these more tailored approaches and move them earlier in the lines of therapy, and hopefully one day get rid of platinum, for example, or paclitaxel, so that it's traditional chemotherapy drugs. We have to be careful when we do that, because we have to make sure that we are achieving a successful response before we do away with a treatment that does clearly have efficacy. So the short answer is that is absolutely the goal. The goal is to move these targeted, tailored treatments earlier in line of therapy. Ultimately, one day we may get rid of these legacy drugs, we'll call them, carboplatin and paclitaxel, but that has to be done in a very thoughtful way so that we can ensure that what we're replacing these drugs with is effective. The second part about radiation, we've already had several clinical trials that have looked at radiotherapy in the management of endometrial cancer. And I will say, if you get 5 GYN oncologists and 5 radiation oncologists in the room, you may get divergent interpretations. But, if we distill it down, the consensus is radiation therapy in endometrial cancer is very good at local disease control, but it doesn't improve cure rates. And so we've seen a change in how radiation is incorporated during the endometrial cancer treatment algorithm. And historically, it was a much more reflexive. Patients with endometrial cancer are going to get radiation. And we've moved away from that into thinking about who would benefit, at what time in their treatment course might they need radiation. And as a result of that, I've seen a large proportion of patients that were receiving radiation previously may not be getting it anymore.
Okay, thank you. That's great. We have a lot of people asking questions about the best way to monitor for recurrence. And could you also comment on the use of the Signatera test and ctDNA-based monitoring of residual disease as surveillance options for folks with endometrial cancer?
These are such good questions. Questions that will require, please understand that the response is a broad response, but we can get much more nuanced in how we discuss these issues. Traditionally, surveillance is based on clinical exam, physical exam with a clinician, and symptom assessment. Sometimes we will incorporate imaging, but imaging is not reflexively utilized in endometrial cancer surveillance. That's a nuanced conversation that every patient should have with their treating physician, because the clinical circumstances are unique in every scenario. But we do visits traditionally every 3 months for the first 2 years, and then every 6 months for the next 3 years. During that time, imaging may or may not be used. And again, that is a conversation that should be had with the provider based on the individual patient and disease characteristics. The question regarding ctDNA is very timely. We are learning more about ctDNA. We understand that we have assays like Signatera that facilitate detection of ctDNA. The question we're obligated to ask ourselves is, what do we do with this information, and what does it mean for the patient? And so I'll give you an example. Say you have a patient diagnosed with endometrial cancer, has surgery, and based on their surgical findings needs chemotherapy. They complete chemotherapy treatment, and then you do a ctDNA assay at the end of treatment and it shows something. What does that detection mean? Does that detection mean that the patient will have a clinical recurrence? If so, when are they going to recur clinically? If I act on that ctDNA marker am I going to improve outcome, most importantly, meaning a biomarker that simply tells me that something is there, but I can't use that data to make an intervention that's going to improve how a patient is going to do is not necessarily going to help me. In fact, I venture to say that may cause, for some patients, a lot of anxiety or worry, or for some providers. So the data is important. The tool is critically important. And I am an advocate for continuing to advance the science in this space. But we have to design the trials that allow us to take the ctDNA data, interpret what it means so that we can use it to improve ultimate clinical outcome for our patients. And that's happening in some disease settings already. We just have to evolve it into our gynecologic cancers, including endometrial cancer, so that there can be a benefit.
Yep, understood. Got it. Thank you. So some questions have come in about maintenance therapy for endometrial cancer. And what are your thoughts on the development of potential maintenance treatments for endometrial?
We've moved into a space where maintenance therapy is used more commonly in gynecologic malignancies, most notably in ovarian cancer with PARP inhibitors, for example, or bevacizumab, which has existed for quite a while now. We also have maintenance strategies in the front line in cervical cancer. When we talk about endometrial cancer, the greatest evolution in maintenance therapy has been the incorporation of immunotherapy with chemotherapy in patients who have advanced stage or recurrent disease. And that was based on FDA approvals that came into play in 2023 and 2024, relatively recent. But it is an immunotherapy-based maintenance strategy when in these patients. In patients who have recurrent disease, we don't really use the phrase maintenance therapy as much because you're treating a disease recurrence. And in the context of recurrent disease, you're on treatment until disease progression or unacceptable side effects. But the studies that I alluded to in my presentation, those clinical trials, as they move into earlier lines of therapy or in the front line, will begin to incorporate maintenance treatment strategies. And there have been other studies. There have been studies that looked at PARP inhibitors in endometrial cancer as a maintenance treatment. You may have heard of those. One was called the UTOLA study. It was an international study. And there was a smaller study here in the United States that looked at the PARP inhibitor rucaparib as a maintenance in frontline advanced or recurrent endometrial cancer. So it's an evolving landscape. We're going to see what else comes into this arena beyond immunotherapy, but that's where it started right now in endometrial cancer.
Thank you very much. Okay, we have a bunch of questions about Keytruda. Keytruda is used after recurrence. Is it used if it can be successful on malignant lymph nodes? If women continue immunotherapy past 2 years, if they're in remission, and are there other immunotherapy options available if Keytruda is no longer working?
So the role of immunotherapy in endometrial cancer started actually in 2017, and that was in a biomarker-specific population. So those were patients who had mismatch repair deficient recurrent endometrial cancer, and it was given as a single agent. And pembrolizumab, so everyone knows, is Keytruda. And we also have dostarlimab, which is an alternate immune checkpoint inhibitor. So when we had these approvals in the recurrent setting, we then looked to move them up into the earlier line treatment, as I alluded to. And there were several large clinical trials that were completed that showed positive findings, an improvement in outcome when immunotherapy like Keytruda or pembrolizumab is given with chemo and continued as maintenance. In the United States right now, there is an FDA approval to give chemotherapy with pembrolizumab or dostarlimab, followed by pembrolizumab or dostarlimab maintenance in patients irrespective of their biomarker if they have advanced stage, and there's criteria that define that, or recurrent disease and have a period off of chemotherapy. So we have access to immunotherapy in these patients. We are using that in the management of the disease, and we're looking to improve upon those results by designing future clinical trials which incorporate other biomarker targeting drugs in this space. The second question about switching, meaning if you're on an immunotherapy of drug A and you stop responding, can you go on to a separate immunotherapy drug B? we don't have data that suggests that that's an effective strategy. Now, we're looking at combinations with immunotherapy in the recurrent setting, and this is an area that we're collecting data actively to figure out, is there a capacity to elicit a response? There have been some small studies that suggest maybe we can do so in some patients, but we're looking to understand more in that space so that we can fill the gap for those patients who progress on immunotherapy, in addition to the clinical trials that were reviewed in the presentation that was shared with you earlier. So I hope that answers the question. It is more nuanced, and so I would advocate that you speak to your clinician who's caring for you to talk about this. But there are approved indications for immunotherapy and endometrial cancer, as we discussed.
Great, thank you. So some questions about radiation therapy. Can pelvic radiation after hysterectomy for ovarian or endometrial cancer result in AML later in life? And what should a person do if they can't have any more radiation?
There are side effects to radiation therapy. Any patient who's going to be advised to receive radiation is counseled by radiation oncologists about those potential side effects. Secondary malignancies, which would include a hematologic malignancy like a leukemia, is one of those. Now, they are uncommon, but they are possible. And thankfully, we've also seen an evolution in the technology around radiation drug delivery. I'm not a radiation oncologist to speak to the nuances, but the technology allows for more tailored delivery of radiation to try to spare what we call organs at risk. These are the neighboring normal organs that we want to protect from the side effects of radiation. So to the question asked, is it a possibility to develop a secondary malignancy? Yes, although that risk is low. And then the follow-up was, what happens if you can't get more radiation? And that is important. There's only a finite amount of radiation that can be delivered to any part of the body. If you exceed that dose, then you begin to have an unacceptably high risk of adverse events or side effects or damage to the normal tissue in that area. So that's why we don't use just radiation after radiation. We need to be more thoughtful about what are the new therapeutic strategies that we can employ. And that's why we have all of these clinical trials to look at new treatment options, because we can't continue to use radiation due to the dose limit for any particular area of the body.
Okay. For those with ovarian and uterine cancer with recurrence, what's the latest treatment, and what is the role of Lynparza and HIPEC is the question.
Yeah. This is an important topic to distinguish early on. Are they concurrent cancers, meaning does the patient have a separate ovary and uterine cancer diagnosed at the same time, or is it a metastasis? What's interesting is that historically, we used to rely just on pathologic characteristics. The pathologist would look under the microscope and say, well, this doesn't look like an aggressive endometrial cancer, so it wouldn't really make sense for it to metastasize to the ovary. But we've moved away from that, actually. And now, very commonly, we will also send molecular testing on the tumors, because what we've seen is many of these are actually metastatic implants, meaning it started in the uterus and metastasized to the ovary. And you can tell because the mutations in the tumors are identical at both locations, in the uterus and in the ovary. So that's the first part. Now, whether they're synchronous, meaning two separate cancers at the same time, or a metastases, the treatment actually overlaps substantially. It's just helping us understand the biology of the disease. And if there's a recurrence, we frequently will biopsy to understand, more about the recurrent lesion. And then the treatment follows paradigms that are very similar to the paradigms of recurrent disease, which, by the way, for ovarian cancer and endometrial cancer, there's a lot of overlap in how we manage recurrent disease. Where it becomes more difficult is if a patient's looking to explore a clinical trial, if you have two malignancies, two cancers at the same time, very frequently those patients are excluded. They cannot enroll on a trial for ovarian or endometrial cancer. And that's why knowing based on the molecular testing is so important, because if it's a metastatic lesion, then suddenly it opens the door to many potential clinical trials in the endometrial cancer space or in the recurrent ovarian cancer space for that matter. So that's what I would advocate. And in terms of PARP inhibitor, again, in that setting, it really depends. Do I believe that it's in ovarian cancer that's metastatic and advanced stage, and I would use PARP inhibitors like I would in an ovarian cancer patient based on various factors. If it's an endometrial cancer that's metastatic, we don't have an approval for PARP inhibitor or definitive evidence for efficacy. We have some clinical trial data from a great study called the DUO-E study that looked at immunotherapy and PARP inhibitors in combination, but that's not approved in the United States. There's additional data that's being acquired. We'll see how that pans out, but that's just information to consider.
Okay, thank you. Changing gears a little bit, if genetic testing results show a variant of unknown significance, how would you recommend that someone proceed?
Variant of unknown significance is not an uncommon finding when we do germline genetic testing. It means that we don't have sufficient data to justify that this is pathogenic, that it results in a downstream impact on the function of that gene. What's important is that you will be, your follow-up in the context of a VUS. Why? Sometimes a VUS, something that's a variant of unknown significance at time point A, over time and with follow-up gets reclassified as a pathogenic variant. That's not common, but it can happen. And so continuing engagement and follow-up with your provider, the companies that do this testing actually track these VUSs and follow them to see if there's been a change in classification over time, and then patients would be notified. But from a day-to-day pragmatic perspective, we don't act on a variant of unknown significance because it doesn't mean that there's an impact on gene function. And we do see these quite frequently when we do send germline genetic testing.
Thank you. Switching gears again, but this is a good question. Do you recommend that if a woman is beyond her childbearing years that she have her ovaries and fallopian tubes removed?
Yeah. There is data around what we call opportunistic salpingectomy. Mm-hmm. So if patients are having surgery, a gynecologic surgery for benign indications or another alternate surgery, abdominal, you can consider removing the fallopian tubes at the time of that procedure in someone who's done having future children. And the reason we say opportunistic is because you're taking the opportunity at the time for a separate surgery to remove the fallopian tubes. Removing the ovaries is more nuanced because there's some population-based data that says that early removal of the ovaries can be associated with increased all-cause mortality, meaning, death from causes independent from cancer. And we don't understand completely why that may be. There's some hypothesis about the implications, for example, in cardiovascular health, et cetera. So we don't reflexively do that. We don't take ovaries out in women who are still relatively young in age, who say, I'm done with my childbearing. Opportunistic salpingectomy can be considered, but again, that's a conversation to have with a provider before a planned operation.
Great. Thank you. Okay, I think this is probably going to be our last question. Do you see precision medicine being used more now than previously for endometrial cancer?
Absolutely. That's one of the most exciting changes in the treatment of endometrial cancer is our understanding of the molecular drivers of the disease. It's really been transformative where, as the use of immunotherapy in these mismatch repair deficient or high tumor mutational burden patients has resulted in cure in patients who would have historically had no treatment options or would have gone on to hospice. And that is not an exaggeration. Our hope is to continue to drive biomarker-directed therapy, which is precision medicine. We're seeing that happen. And we continue to hold ourselves to the standard of learning more about the disease so that we can do better on behalf of our patients. And that is our future, undoubtedly.
That's great. Okay, thank you so much, Dr. Eskander. That was a great presentation, super helpful. Appreciate your time today. And there were, our pleasure. There were many questions we didn't get a chance to answer today, but we will be sending out an email to everyone after this session today with more resources and links. So look for that in your inbox. And of course, you can always find us online, our website, ocrahope.org. And that's all. Thank you so much for your time and for joining us today.